Welcome to this Pearl of Laboratory Medicine brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls as well as other free educational material at traineecouncil.org.
Hello, my name is Joud Hajjar. I'm an assistant professor of medicine in adult allergy and immunology at Baylor College of Medicine and Texas Children's Hospital. These slides were prepared by Dr. Maha Sayed and myself. Welcome to this Pearl of Laboratory Medicine on primary antibody deficiency. In this Pearl, we will take a brief look into the most common primary antibody deficiencies. On the completion, you should be familiar with the following. Recognize clinical patterns suggestive of primary antibody deficiency, we will refer to as PAD. Learn about different presentations of PAD. Be familiar with the diagnostic methods of PAD. Be familiar with the common treatments used for PAD, and be familiar with complications caused by PAD. Primary antibody deficiency syndromes are defined as a group of rare disorders characterized by inability to produce clinically effective immunoglobulin responses. Some disorders result from genetic mutations in genes involved in B-cell development, whereas others appear to be complex polygenic disorders. The prevalence, symptoms, diagnosis, and treatments of each of the major humoral immunodeficiencies will be discussed. Here's a list of the primary antibody deficiency that we'll be discussing in this presentation. Selective IgA deficiency, CDID, specific antibody deficiency disorders, Gammaglobulinemia, both X-linked and autosomal recessive, transient hypogammaglobulinemia of infancy, IgG subclasses deficiency, selective IgM deficiency, and hyper-IgM syndrome. Selective IgA deficiency is the most common primary antibody deficiency. Its prevalence in the Caucasian population is 1 in every 400. It probably arises through several pathogenic mechanisms. However, the exact mechanism is not known. It is hypothesized that it is caused by defects in B cells or defective interaction between B cell and T cells. People with this disorder have absent immunoglobulin A, IgA. IgA protects against infections of the mucous membranes lining the mouth, airways, and digestive tract. From an immune standpoint, patients have very low or undetectable IgA levels, usually below 7 mg per deciliter, with normal IgM and IgG levels. Few patients might have abnormal specific antibody responses. 2/3 of patients are healthy and are asymptomatic. Symptomatic patients may present with autoimmune disorders such as idiopathic thrombocytopenic purpura, autoimmune hemolytic anemia, rheumatoid arthritis, systemic lupus erythematosus, thyroiditis, and vitiligo, or sinopulmonary infections with encapsulated bacteria, gastrointestinal disorders such as GERD infection, nodular lymphoid hyperplasia, celiac disease, and inflammatory bowel disease, or allergic diseases such as asthma, allergic rhinitis, atopic dermatitis, and food allergy. In rare cases, anaphylactic transfusion reactions to plasma-containing blood products such as whole blood, fresh frozen plasma, and immunoglobulin preparations containing IgA might happen. The mechanism behind this is the presence of antibodies directed against IgA, which can form in some patients with undetectable levels of serum IgA. Reactions occur when anti-IgA antibodies react to small amounts of IgA in plasma or immunoglobulin products. In rare cases, selective IgA deficiency may progress into CDID, common variable immunodeficiency. In these situations, symptomatic patients should be followed clinically and by immunoglobulin levels longitudinally to determine if CDID develops. For laboratory evaluation, measurement of serum concentrations of IgA, G, and M are performed. A diagnosis on selective IgA is confirmed with an isolated deficiency of serum IgA in the presence of normal IgG and IgM. Treatment may include prophylactic antibiotics to reduce risk of infection and occasionally a trial of immunoglobulin replacement therapy if the patients have specific antibody deficiency and failed prophylactic antibiotics. IgG Subclass Deficiency. The IgG class of antibodies is composed of 4 different subtypes of IgG molecules: IgG1, IgG2, IgG3, and IgG4. Patients should have persistently low levels of 1 or 2 of the IgG subclasses with normal total IgG, A, and IgM to be diagnosed with IgG subclass deficiency. Pathophysiology is unclear, as no specific gene has been identified. Gene deletions, transcription errors, and allotypic variations are just some of the mechanisms by which this disorder may occur. Patients may present with sinopulmonary infections and gastrointestinal infections. Laboratory evaluations include clinical history and physical exam, followed by total serum IgG, IgA, IgM, and IgE. IgG subclasses obtained at initial evaluation and only if vaccine response is impaired. Antibody titers to protein and polysaccharide antigens like diphtheria, tetanus, Haemophilus influenza type B, and Streptococcus pneumonia. Treatment includes prophylactic antibiotics, and immunoglobulin replacement therapy, IgG-RT, is reserved for patients with abnormal antibody responses and frequent or chronic infections. Common variable immune deficiency, CDID, is the most common symptomatic primary immunodeficiency in adults. Its prevalence varies from 1 in 10,000 to 1 in 100,000. The hallmark of CDID is poor antibody production, low IgG, IgA, and/or IgM, and poor responses to protein and polysaccharide vaccines. Clinically, patients develop recurrent infections, mainly sinopulmonary. 20% of patients have non-infectious complications such as autoimmunity, chronic lung or GI disease, and increased risk of malignancy. Laboratory evaluation includes the measurement of immunoglobulin levels, the demonstration of impaired responses to vaccinations, and exclusion of other causes of these abnormalities. Immunoglobulin G IgG replacement therapy is the standard of care in CVID and has led to decrease in infections and improved survival. We discussed the similarity and differences in the diagnostic criteria of CVID between the European Society of Immunodeficiency (ESED) in 2014 and the International Consensus Document ICON 2016. Both require low IgG levels, low IgA and/or IgM levels, and that other causes of hypogammaglobulinemia to be excluded. The ICON requires the presence of impaired vaccine responses, while the ESED foregoes this criteria if the patient had low memory B cells. The age of the diagnosis should be above 2 years for ICON and above 4 years in the ESED. The most striking differences is that the ICON criteria allows for CVID diagnosis based on laboratory findings solely, without the presence of clinical symptoms such as recurrent infections, autoimmunity, lymphoproliferation, or positive family history, while ESED requires the presence of at least one clinical feature in addition to laboratory findings to establish the diagnosis of CVID. Specific antibody deficiency is a primary immunodeficiency disease characterized by normal immunoglobulins, IgA, M, and total IgG, but impaired specific antibody responses to polysaccharide vaccines. Normal B cell numbers, but with recurrent infections and diminished antibody responses to polysaccharide antigens following vaccinations. Its prevalence is 5 to 10% in children more than 2 years old. The etiology is unclear. It may be caused by defects such as congenital molecular abnormalities. For subjects aged between 6 to 65 years, a normal response is defined as protective antibodies to 70% of the serotypes tested, with at least a 2-fold increase from baseline level. Symptoms include recurrent sinopulmonary infection, and treatment includes prophylactic antibiotics, vaccination with a conjugate pneumococcal vaccine, Prevnar, while immunoglobulin replacement therapy should be preserved for patients with severe infections who fail or are unable to tolerate prophylactic antibiotics. This table provides value to assess the polysaccharide vaccine Pneumovax response in patients with specific antibody deficiency. Immunization with a polysaccharide pneumococcal vaccine is used to assess immunological responses to polysaccharide antigens in patients over 2 years of age. Other than being a tool in diagnosis, vaccination enhances immunity to a common respiratory pathogen in patients suffering from recurrent infections. The Pneumovax vaccine response varies depending on the type of the phenotype administered. The value of 1.3 milligram per deciliter is considered to indicate protective specific antibody level. For patients above the age of 6 years, protective antibodies to 70% of the serotypes tested with 2 to 3-fold increase in the baseline of antibody is considered appropriate response. Specific antibody deficiency, indicating impaired antibody response to pneumovax, is classified into mild, moderate, and severe. Severe SAD indicates that patients only have less than 2 protective titers, which means that their levels are above 1.3 microgram per ml. Moderate SAD is diagnosed when patients are able to mount protective antibodies to more than 3 serotypes, but less than 70% of serotypes for age above 6 years and less than 50% for ages less than 6. Mild SAD indicate that patients have failure to generate protective titers to multiple serotypes or failure to generate a 2 or 3-fold increase in 50 to 70% of serotypes. Finally, memory SAD indicates that patients had loss of protective antibody levels within 6 to 12 months after vaccination. Agammaglobulinemia occurs from failure of B-cell lymphocyte precursors to mature into B cells and the plasma cells needed to produce immunoglobulins. Its prevalence is 1 in 379,000 U.S. live births. It's either X-linked, we call it XLA, or Bruton agammaglobulinemia, and it's due to a mutation in the BTK gene, which is responsible for about 85 to 90% of cases. Or it could be autosomal recessive due to variation in genes such as the IgLL1, CD79A gene, BLNK, LRRC8, CD79B gene, PIK3 receptor 1, and TCF3 gene. All those together shape about 10 to 15% of the cases. Symptoms include upper and lower respiratory tract infections with encapsulated bacteria such as Streptococcus pneumonia or Haemophilus influenza, mycoplasma and neuroplasma pneumonia, and septic arthritis. Pseudomonas and Staphylococcus sepsis, particularly in the setting of transient neutropenia, and enteroviruses infections such as polio, Coxsackie, or echoviruses that can cause chronic diarrhea, meningitis, or even fatal disseminated infection. The definitive diagnosis relies on immunophenotyping by flow cytometry and gene sequencing. For further evaluation, agammaglobulinemia, deficient antibody responses to immunizations, and absent or marked reduced B cell and peripheral blood, mainly CD19 and CD20, is seen. Lifetime immunoglobulin replacement therapy is indicated for all patients. These images show B cells phenotyping of memory cells in peripheral blood samples. The first plot is from a patient with X-linked agammaglobulinemia showing absent CD19 positive cells in comparison to the second image on the right, where we see the control have normal CD19 positive population. Transient hypogammaglobulinemia of infancy is a common immunodeficiency affecting children usually younger than 2 years. IgG is transferred through the placenta from mother, and in 3 to 6 months, IgG wears off. And if the infant's immune system is not mature, the infant develops transient hypogammaglobulinemia. No inherent defect of B cell maturation or function or defects in specific antibody responses are usually seen. Low IgG levels and variably low IgA and rarely low IgM levels, with normal specific antibody responses in most cases and normal B cell numbers. The symptoms include recurrent sinopulmonary infections, GI infections, candidiasis, and sometimes meningitis. To diagnose, we should see low IgG, IgA, and IgM levels, normal specific antibody responses in most patients, and normal B cell numbers. Patients with frequent and or more severe infections are treated with prophylactic antibiotics or immunoglobulin replacement therapy until their own immunoglobulins normalize. Hyper-IgM syndrome is a heterogeneous group of genetic disorders resulting in defects of immunoglobulin class switch recombination CSR, with or without defects of somatic hypermutation. Its prevalence is 1 in 100,000, and it could be either X-linked due to mutation in the CD40 ligand or autosomal recessive due to mutation CD40, HUNG, and AID. CD40/CD40 ligand deficiency is a combined immunodeficiency because of T-cell involvement. Severe infections such as PJP and severe CMV disease and mucocutaneous candidiasis could occur. Complications include failure to thrive in infants and liver disease, especially cirrhosis and cholangiocarcinoma. Laboratory evaluation include low IgG, IgA, and IgE with either normal or elevated IgM. Patients might have neutropenia. The major finding is absence of class-switch memory B cells, which are CD19 positive, IgM, and IgD negative. An example will be shown in the next slide. Treatment is to provide PJP prophylaxis, antibiotics, GM-CSF, which is granulocyte colony stimulating factor for neutropenia, immunosuppressive regimens for autoimmune manifestations, and finally, hematopoietic stem cell transplant could provide a curative option. Activation-induced cytidine deaminase, uracil, DNA glycosylase deficiency are less common forms of hyper-IgM and are characterized by recurrent sinopulmonary infections, mostly due to encapsulated bacteria, lymphoid hyperplasia, tonsillar hypertrophy, autoimmunity, and malignancy. This plot shows the appearance of normal switch memory B cells on peripheral blood analysis, which is usually absent in patients with hyper-IgM syndrome. Selective IgM deficiency is a rare immune disorder with absent or very low immunoglobulin M, with normal IgG and IgA antibodies. Its etiology is unclear and may be caused by B cell defects or disorders in T cell help and possibly chromosomal defects. It's associated with autoimmune disease such as systemic lupus erythematosus, rheumatoid arthritis, Crohn's disease, celiac disease, polymyositis, and Hashimoto's thyroiditis. Clinical features sometimes include sinopulmonary infections such as otitis media, chronic sinusitis, bronchitis, and other infections. The infectious manifestations are most commonly seen in children, while adults present with associated allergic and autoimmune disorders in addition to those infections. Allergic diseases include rhinitis and sinusitis. The diagnosis requires presence of low or absent IgM with normal antibody levels, IgG and A. Ruling out other conditions causing low IgM levels are important too. Treatment: there is no commercially available highly enriched IgM immunoglobulin preparation. Treatment with immunoglobulin therapy may be considered in those with selective antibody deficiency. In this slide, we discuss the laboratory evaluation for humoral immune deficiency. This should begin with a targeted history and physical exam for recurrent infections and autoimmunity. Following laboratory evaluation should be considered for quantitative serum immunoglobulin with age and sex matched controls, measurement of antibody production, polysaccharide vaccine, pneumovax, or protein-based vaccination such as tetanus and diphtheria. The measurement of quantitative antigen-specific IgG titers pre- and post-immunization will give important clues. 4 weeks post-immunization levels should be within protective range. Cutoff varies with each vaccine. Peripheral blood lymphocyte subset analysis should additionally be considered. These tables provide a summary of some of the CD markers that we use in diagnosing patients with primary antibody deficiency disorders. T cells are CD3 positive, and they are either CD4 or CD8 positive. CD19 is the marker for B cells, and CD27 marker on B cells indicates that those cells encountered antigen and became memory B cells. CD19, CD27, which express both IgD and IgM, suggest that those B cells did not class switch, and when IgD and IgM expression is lost, this indicates that those B cells have undergone class switching to produce IgA, IgG, or IgE. CD19 positive CD38 bright cells are transitional B cells, while CD19 positive CD38 negative or low and CD21 low cells are autoreactive B cells that might be expanded in patients with CDID who have autoimmunity. This figure summarizes the evaluation algorithm for primary antibody deficiency disorders. Patients with recurrent sinopulmonary infections or infections and autoimmunity or infections with malignancy should have immunoglobulins IgG, IgA, and IgM levels evaluated. For patients with normal levels, we should assess the vaccine responses. For normal response, we should evaluate periodically or reassess for secondary causes. A poor vaccine response with normal immunoglobulin implies that those patients have selective antibody deficiency or SAD. For patients with low levels, other causes of hypogammaglobulinemia should be ruled out, such as protein-losing enteropathy, proteinuria, or medications causing hypogammaglobulinemia, such as steroids or anti-epileptic medications. If none of those causes are confirmed, treatment should be directed to the underlying cause, and those patients are considered to have secondary hypogammaglobulinemia. Otherwise, the next step should be to assess vaccine responses. Low levels of IgG, IgA, and IgM or poor responses might suggest diagnosis of CDID if the other criteria that we have discussed earlier are met. Thank you for joining me on this pearl of laboratory medicine on primary antibody deficiency.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.